Hello, I'm Dr. Laurence Sperling, Chief Medical Officer for the Family Heart Foundation. Cardiovascular disease continues to be the number one cause of death in our nation. With the closing of Heart Month in February, we're now stepping into March, kicking off Women's History Month and Lp(a) Awareness Month. Today, we're going to focus on the emerging understanding of the prevalence of what I call cholesterol with an exclamation point, lipoprotein(a). Lp(a), unfortunately, despite having elevated Lp(a) levels in 1 out of every 5 people worldwide, Lp(a) is under-recognized as a risk factor, and therefore many people are living with significant cardiovascular risk. Lp(a) is a genetically determined factor, and it runs in families. I'm pleased to be joined today by Dr. Jane Morgan, a leading cardiologist, a women's heart expert, and vice president for Hello Heart. She's devoted to education to the public on important health topics and addressing inequities in healthcare, and has been serving the Association of Black Cardiologists for many years. So, Dr. Morgan, thank you for joining me today for this important conversation.
Thank you, Dr. Sperling. It's a pleasure.
Well, let's get right to it. So I mentioned lipoprotein(a) as cholesterol with an exclamation point. I refer to it as the triple threat. It increases atherosclerotic plaque development, it increases inflammation, and it increases thrombosis, the risk of clotting. And it runs in families. Why do you think it's important for our listeners today to understand lipoprotein(a), to be aware of it, but to move past just awareness and speak with their clinician or clinical team about having their lipoprotein(a) measured?
As you know, as a physician, we've known about Lp(a) or lipoprotein(a) for a long time. But for the most part, most doctors have not tested for it, still do not test for it. And part of that is, we'll give you a little secret, is we don't really like testing for things that we can't really treat. I mean, we haven't really had a pharmaceutical intervention or any type of therapy for Lp(a). And so what is that? It is a bad cholesterol. I know you think of LDL as the bad cholesterol. This one is actually somewhat worse. As Dr. Sperling says, it does run in families. There's a genetic linkage to it. We see it a lot in African American populations and Southeast Asian populations, but in other populations as well. And it really accelerates atherosclerosis, so the development of plaques in your arteries, and those plaques can lead to heart attacks. And many people with elevated Lp(a)s can have earlier heart attacks as well. You can see people in their 20s or 30s or 40s having heart attacks. And if you have a family history or someone in your family who has had sort of this unexplained cardiac event at an earlier age, say before 45, then it may be something worth exploring. It's LP parenthesis A parenthesis Lp(a). The good news is, there are a number of things that we can do, and there are a number of pharmaceutical companies actually in phase 2 and phase 3 trials developing therapies actively, even as you're listening to this broadcast today, that hopefully will have a really significant impact on people with elevated Lp(a)s, bringing that level down, but also not just bringing it down, but actually decreasing your risk of heart disease. And what we don't know is if lowering Lp(a) actually decreases your risk of heart disease. We suspect it does, just as we follow LDL, but we've got to get some evidence-based medicine for that.
Yeah, well, thank you. And as you mentioned, the science is exciting and really at a critical point in terms of translating what we know about lipoprotein(a) to potential treatment options. With my patients, I frequently am ordering a lipoprotein(a) to help them better understand their risk because it is what I call a risk magnifier. And awareness alone helps me as a clinician. I'm a preventive cardiologist, be more aggressive in my preventive strategies for those living with an elevated Lp little a. And then I talk about what we, in medical terms, translate to cascade screening. But that just means we've identified not only a person at risk, but a family at risk. You also alluded to the gaps in care and knowledge. It is Women's History Month and Lp(a) Awareness Month. What can you tell us about what we know about lipoprotein(a) that affects women at a greater level and Black people at a greater level than the general population? And how can we make steps to not only improve upon awareness, but addressing preventive strategies in populations that are often left behind or under-recognized in terms of their comprehensive risk?
That is a multi-pronged question. And when we begin to approach global populations, including the African American population, including women's health, there are always levels of nuances and differences that have to be considered. One of the things that we think about with regard to women, and then I'll also talk about Black women, is, what happens during perimenopause, what happens during menopause. And when we look at the perimenopause phase, which really are those years leading up to menopause being defined as going one consecutive year without a menstrual period. So one consecutive year without any bleeding at all. And those years prior to that, really, we are increasingly understanding, really portend a higher risk of heart disease for women. Prior to menopause, a woman's risk of heart disease is about half that of a man. But once she enters menopause, it's equal to that of a man for a number of reasons. It's not just dropping estrogen levels, because we have estrogen receptors in different areas of our body, but we have increasing blood pressure as your arteries stiffen, as your estrogen levels decrease. And we see what? Rises in cholesterol as well, including that LDL. Development of visceral fat, central obesity. All of these are risk factors for heart disease. They can all occur concomitantly during menopause. And so one of the big questions has been with regard to Lp(a) and measuring Lp(a), which generally now our thought is we sort of measure it once in a lifetime and move towards therapy. The question is that really effective for women when we think about all the different phases that a woman transitions through in life, and whether or not it's worth looking at measuring it prior to menopause and then 10 or 12 years later after menopause? Is there a difference? I'm asking that question. We actually do not know the answer to that question, but it's an example of how women's health has sort of been relegated to the side, and we're not really actually giving full considerations to everything that's going on in the scope of the woman's aging process and development process. And maybe there's not a one size fits all. Lp(a) may be in that bucket. In other words, if you have a normal Lp(a) prior to menopause, should that be remeasured at some point? We don't know the effects. We actually do not know the answer to that question. And so if you're listening to this, Lp(a) is really on the precipice. We don't necessarily have treatments for it. It's coming. Several companies are in phase 3 trials. We definitely, if your physician is testing for it, and bravo to Dr. Sperling for being a preventive cardiologist and actually testing for it. Many physicians do not. And we need to be able to understand what is that aggressive intervention in people who have these elevated levels. When we talk about Black females as well, there's an increased risk of Lp(a) running in families, but we also know that there's something called the weathering effect, or this allostatic load, meaning that Black women tend to age biologically in a more advanced manner. Your bodies are older than your birth date. And that portends a lot of risk with regard to when we're doing cancer screenings, when we're doing mammograms, and should those types of screenings be done earlier based on your biologic age, the effects of high effort coping in a society that is both gender conscious, and race conscious. And the long-term effects of living in a society like that have demonstrated shortened telomeres. Those are the end caps of the DNA in Black women. And what do we see as evidence of that? Tend to enter menopause earlier, about a year or a year and a half earlier, which means your risk of heart disease increases earlier. You start that increased risk of heart disease. So any number of things. And when we talk about LP little a, that is going to be rolled into it. And certainly as we have therapies become available, we'll see more and more and more conversation about this as we try to determine how best to apply these therapies to all different populations. And that means there'll be a lot of unanswered questions that we will need to pursue.
Yeah, let's cut to the heart of our conversation today and to some questions that I think there are answers for. First and foremost, we, meaning the Family Heart Foundation, greatly appreciates our partnership with the Association of Black Cardiologists. What do we know? We know there are ways that people can learn more about lipoprotein(a) as a potent cardiovascular risk factor. The Family Heart Foundation has a website that will lead them to an opportunity to order a kit that will allow them to assess their LDL cholesterol and Lp(a) at home. It's called Cholesterol Connect, and it's free of charge. Additionally, the Family Heart Foundation has care navigators, experts that can guide people who might find out they have an elevated cholesterol or elevated Lp(a), and that individual can be given some expert guidance on next steps and conversations with our clinicians and clinical teams. But I was wondering, as we close, any comments on behalf of the work you do or ABC about why it is important to connect this Women's History Month and Lp(a) Awareness Month, because 1 out of every 5 people are living with an elevated Lp(a), and the majority of them are unaware. It's really important for them to be aware of their risk, to treat their risk in a preventive fashion, and to be aware that their risk extends to others that they love.
And that's the key. It's not necessarily that you're just doing it for yourself. You're also doing it for others, because if it's determined that you have an elevated Lp(a), then we actually want to test your family members as well. And everyone has the opportunity then to have really good preventive care to make certain that you can age in as healthy a manner as possible. It's about healthy aging. It's about longevity. You know, women live about 6 years longer than men, but we spend more of our lives in poorer health. And part of that is because clinical trials and research really don't focus on women beyond the reproductive organs. And the same holds true for minority populations, and especially the Black population, who's been reticent really to participate in clinical trials because of a lot of previous atrocities. But also, companies are not pursuing African Americans. We don't have principal investigators that are African Americans. Most participants in clinical trials are there because a trusted physician has approached them. 80% of the African American population is seen by a Black physician. If Black physicians are not principal investigators, and that's the number one reason of any race, any culture, any gender of actually entering into a clinical trial, you can see why there's such a dearth. So we really need to have representation at every single level, such that all of these drugs and pharmaceuticals and interventions that go before the FDA are actually relevant to all populations, and we can use them in as effective manner as possible.
Well, Dr. Morgan, thank you so much for joining me today for this conversation. Lp(a) awareness is of great value to so many, and I appreciate you making the important points you've made today, and the great work you do in the organizations that you champion and serve. So thanks again for joining me today.
Thank you so much, Dr. Sperling.